Hello and welcome. My name is Sarah Maines, the Liver Cancers Program Director at Global Liver Institute, the world's largest liver patient organization. At GLI, we bring together more than 200 organizations across our councils, campaigns, and events to advance liver health as public health priority. Our mission is to prevent liver disease, improve early detection, and scale the most effective strategies for supporting individuals and families impacted by liver disease and liver cancers. In today's session of our October is for Livers campaign series, we take a closer look at HCC, hepatocellular carcinoma, in the United Kingdom. As cases continue to rise globally, understanding HCC has never been more critical. The discussion will highlight our current treatment options across the UK, explore how care is delivered regionally, and examine emerging approaches that aim to improve outcomes. We are pleased and honored to welcome Dr. Abid Suttle today from the Institute of Liver Studies at King's College Hospital. Dr. Suttle, thank you so much for joining us today and sharing your insights on HCC and to provide a valuable perspective on the treatment landscape in the United Kingdom. Welcome.
Sarah, thank you. Thank you for inviting me to speak today and for your kind introduction. I'm very happy to speak about something I'm very passionate about, and I think everyone in the liver community needs to be really passionate about, because it is a cancer which is increasing in frequency, increasing in its incidence and in mortality. So I'm very pleased to be speaking to you today. In terms of the outline of the talk, at various points I'll talk about the healthcare system in the United Kingdom, because that's intrinsically linked with the care we give. I want to outline what hepatocellular carcinoma is, the incidence, how frequent it is, and the risk factors for its development, as well as diagnosis and treatment. I'm going to outline the multidisciplinary team delivery of care and how that's done on a regional basis in the United Kingdom, and then talk to the challenges in service delivery and management in the UK. And the most important part of the talk is concentrating on how we reduce mortality from HCC. And in many ways, because of the type of healthcare system we have in the United Kingdom, we may be uniquely placed to introduce national policies which are going to be really important, but I'll allude to that as we go along. So firstly, I just wanted to outline in brief the national health system, which you probably have heard about. So in the UK, the national health system was set up after the Second World War to provide everyone in the United Kingdom with healthcare based on need and not on the ability to pay. That's really a quote from the introduction of the service. It's a huge service. 1.3 million people in England, or 1 in 40 people, work in the NHS. It is funded by taxation and national insurance, a specific type of tax. But then for everyone, healthcare is free at the point of delivery. So all cancer investigations and treatments are free at the point of delivery. There is a cost that goes along with some medications, but that doesn't apply to cancer care. I'm proud to work in a system like this, and the philosophy is hugely admirable. In reality, of course, it's more complex. The system is somewhat overburdened. The treatments we give need to undergo regulatory approval, and I'll outline why that's positive and negative. And the system's stretched. Waiting lists for treatments are longer than we'd want them to be. So in order to answer the first question, really, I alluded to in the talk outline, what is hepatocellular carcinoma? We always need to ask a more fundamental question, which is, what is cancer? Because cancer is an umbrella term which encompasses hundreds of different diseases which have common features, some commonality between them. And I'm going to start by saying our bodies, the functional unit of our bodies, are the cell. Our bodies are composed of millions of cells. All our organs, our bones, our immune systems are all composed of cells. Under normal circumstances, the functions of a cell, what it does, are very tightly regulated. What functions it performs, how long the cell lasts for in your body before it dies and is replaced by a process called cell division, where a cell will divide in two to replace old cells. This is all hugely tightly regulated. And the recipe book, if you like, or the instruction manual, is contained within the DNA, within the cell nucleus, within the central part of the cell. Under certain circumstances, this instruction manual can go wrong, and notably when there are mutations in the DNA, and the cells can start to function abnormally. They don't do what they're supposed to do. They don't die when they're supposed to die, and they're not regulated in the way they should be. And so a cell can become a cancer cell as a consequence of mutations in the DNA. A collection of cancer cells is what we call a malignant tumor, which can then take over the organ that the cancer originates in and can metastasize. It can break off and the cancer can spread around the body. And we call this metastatic cancer. So hepatocellular carcinoma is also known as HCC or hepatoma or liver cell cancer, and it's the most common primary liver cancer. So I'll just take you through this slide. If we think of a liver lesion, a lump in the liver, it can either be benign or non-cancerous or cancer. Cancers can be primary, they develop within the liver substance, or secondary, they've spread from a primary cancer in another organ. The two main types of liver cancer are hepatocellular carcinoma, which is derived from the cells, the main cells within the liver, and cholangiocarcinoma, which is derived from the cells which line the bile ducts. The bile ducts are the tubes which transmit bile, which is produced in the liver cells. There are some other rare types of liver cancer, fibrolamellar HCC, and mixed tumors, but I won't talk too much to those. So the strict pathological definition of HCC is an epithelial tumor showing hepatocytic differentiation. In other words, a cancer which is derived from the liver cells or the hepatocytes. As we've said, it's the most common form of primary liver cancer. Worldwide in 2018, HCC represented 80% of primary liver cancers, as opposed to 15% with cholangiocarcinoma and 5% with other histology. This doesn't reflect what's happening worldwide, and in certain parts of Europe and Oceania, cholangiocarcinoma is much more common. So these are figures from the UK between 1997 and 2017 showed that the split was more 50%, 38% between HCC and cholangiocarcinoma. In the United States, HCC accounted for 77% of primary liver cancers, so more like the worldwide figures. This slide just summarizes the huge global burden of primary liver cancer and how important a public health problem it is. So in 2020, in excess of 900,000 people were diagnosed with liver cancer and 830,000 patients died. It's predicted that by 2030, with current trends continuing, more than 1 million people will die from liver cancer. And it's the third commonest cause of cancer-related death worldwide. This slide just shows this worldwide epidemiology in a bit more detail. And let's just concentrate on the two panels here, incidence and mortality. Incidence, in other words, how frequent the cancer is, with the darker colors being areas where incidence is higher. And mortality, in other words, death rate, again, darker colors indicating a higher mortality. What's notable is that the incidence is highest in areas where viral hepatitis, chronic viral hepatitis type B and C are most common. And worldwide, viral hepatitis is the most common risk factor for liver cancer. And that's reflected in the mortality as well. Now, this is a slightly complex panel, but on this panel, you look at the number of cases versus the estimated number of deaths. And the ratio in liver cancer is 1, which suggests it's a cancer associated with a high death rate. Compare that to thyroid cancer, for example, where the death rate is the number of deaths per year is much lower than the number of people who are diagnosed on a yearly basis. In the United Kingdom, overall, liver cancer is the 17th most common cancer, the 20th in women and the 15th in men. And between 1997 and 2017, we've seen a trebling in the incidence and mortality from liver cancer. Despite improvements in diagnosis and management, the 1, 2, and 5-year survival rates remain very suboptimal. Liver cancer is the only major cancer in the UK which is not only increasing in incidence, it's also increasing in mortality. So all the other major causes of cancer have shown a reduction in mortality, whereas liver cancer is still showing an increase. I just wanted to talk a bit about health inequality. I'm sorry this slide didn't project very well. This is data from the British Journal of Cancer in 2017, and it looked at how common cancer was in certain ethnic groups, with the white ethnic group being the control group, what you would expect, for want of a better word. The incidence was higher in Asian and Black ethnic groups and lower in those of mixed or multiple ethnicities. Part of this may be explained by the risk factor profile, the highest incidence of viral hepatitis in the Asian and Black ethnic groups, but there are probably some other factors as well. What we see is that liver cancer incidence rises from the age of 40 to 44. This rise is steep in males and steady in females, with the peak incidence being in the 80s. Consistently across the world, liver cancer rates are higher or HCC rates are higher in males than females. Importantly, the incidence of liver cancer is linked to social deprivation as well. So this slide looks at how common liver cancer is by deprivation quartile. And the more deprived a population is, the higher the incidence of HCC. So in tackling this disease, we need to think about the particular groups that are affected and whether our management strategies are engaging them in the correct manner. This slide shows incident rates across the UK, and If we take England as the reference, the rates of liver cancer are higher in Scotland and Wales and lower in Northern Ireland. So in terms of causes of HCC in the UK, it's estimated that 49% of cases are preventable. The majority of cases occur in the context of what we call steatotic chronic liver disease, and that is chronic liver disease caused by alcohol or obesity and the metabolic syndrome. The proportion caused by chronic viral hepatitis is reducing with the advent of effective antiviral therapy, but still remains significant, 10% of cases. Smoking is an additive risk factor. I think that's the best way to think of it rather than a risk factor on its own. So how does hepatocellular carcinoma develop? Well, in the vast majority of cases in the Western world, 90%, it occurs in the context of cirrhosis. So what is cirrhosis? Well, we start with a healthy liver, and then a variety of risk factors, alcohol, chronic viral hepatitis, the metabolic syndrome, can cause chronic damage to the liver and chronic damage to the liver cells. Think of inflammation as being a soreness in the liver, which changes to fibrosis. The soreness in the liver gets replaced by scar tissue. And we use the term cirrhosis when the damage in the liver is sufficient for complications to potentially ensue. And these complications include liver cancer and liver failure. At a genetic level, there are people who have a genetic predisposition to cirrhosis and liver cancer. These are what are called polymorphisms in the genes. There are people who are relatively protected, seemingly, against chronic liver disease. But it's during this process of chronic damage to the liver cells that a variety of mutations occur. So this chronic damage to the liver cells causes mutations to occur in the DNA within the liver cells. And once a certain accumulation of mutations has occurred, this is the context in which HCC develops. In 10% of cases, it can occur in a non-cirrhotic liver, with the risk factor notably being hepatitis B or fatty liver disease, which we'll talk about in a second. So they say that a picture is worth 1,000 words, and I'm a big believer in that. So this is what a normal liver looks like. It's a tawny brown color. There are two lobes. There's a right lobe and a left lobe. You can see it's smooth. The edges are sharp. This is a cirrhotic liver. What we call the morphology or the appearance of the liver has changed very significantly. Instead of it being smooth in outline, you've got swathes of scar tissue which are separating nodules or balls of liver cells. And this picture shows a cirrhotic liver with a cancer here. So this cancer will have developed within one of these nodules and will have increased in size. So in terms of defining the risk factors for hepatocellular carcinoma, it can be cirrhosis of any cause. It can occur in patients who are non-cirrhotic, notably chronic hepatitis B infection. We are seeing HCC developing in patients with fatty liver disease who don't have cirrhosis, and that could be a real problem going forward. Elderly patients. You can get malignant transformation of benign lesions such as adenoma, and fibrolamellar HCC is a rare subtype usually seen in younger patients. We've talked about the influence of age and male sex and smoking. So what's the clinical context in which we diagnose hepatocellular carcinoma? We hope to diagnose it during screening, and I'll talk a bit about screening a bit later. This gives you the best chance of diagnosis at an early stage when the patient can have a curative treatment. An incidental diagnosis, we are increasingly using imaging to investigate any problem. It's very common to get a scan, and there can be almost an accidental finding of a lesion on a scan performed for another reason. HCC can be diagnosed during the investigation of abnormal liver tests or the investigation of liver failure. If HCC causes symptoms, pain, loss of appetite, loss of weight, fever, it's often quite advanced. And what we find is that in patients who are diagnosed in the last two categories often have advanced disease. So when we talk about cancer screening, we are identifying a group of people who are at risk of developing a cancer. And we are, on a periodic basis, applying a test which is acceptable to the patient in terms of going through the investigation and associated with a high chance of diagnosing the cancer at an early stage. And thinking about this, patients with cirrhosis and patients with some forms of chronic hepatitis B should be a group who would benefit from surveillance, and that's what's recommended. Patients who should undergo screening include those who would be fit for anti-cancer therapy, all patients with cirrhosis, and certain non-cirrhotic patients with hepatitis B. In non-cirrhotic MASLD, so in patients with fatty liver disease but without cirrhosis, the benefits from screening are not well defined. At the moment, the standard of care, The standard of care is to perform 6 monthly ultrasound scans of the liver with a 6 monthly alpha fetoprotein. So an ultrasound scan is in general an acceptable test. It involves jelly on a probe, and you do a scan of the liver without usually any pain. Alpha fetoprotein is a blood test. It's a tumor marker. So these tests are usually acceptable to the patients in terms of having them done, but they're imperfect, especially in diagnosing early stage cancers. So you have an 80% chance with screening of diagnosing a cancer at any stage, but only a 60% chance of diagnosing with these techniques a cancer at a very early stage. And the challenges in the UK for screening include the huge unrecognized liver disease in the community. So fatty liver disease is estimated to affect 1 in 5 in the UK. We don't have a national database of patients with cirrhosis, and we don't have an agreed national policy that we do, for example, for breast cancer screening. Particularly important is the recall policy in case of abnormal findings. And what tends to happen is that practice varies from unit to unit. And this is reflected in this slide. So despite us knowing the risk factors, 36% of patients are diagnosed with HCC via an emergency pathway. And this will be when they present with cancer-related symptoms or liver failure, with less than 10% then being in a position to receive a curative treatment. compare this to 17% of people being diagnosed during a screening. And if you're diagnosed during screening, you have a much higher chance of receiving a curative treatment. Still not good enough. 36% is still not good enough. As we've said, early stage cancer, it's likely the patient will have no symptoms. With more advanced cancers, there can be symptoms related to the tumor infiltrating the liver itself, abnormal liver tests, features of liver failure, such as jaundice and ascites, and abdominal pain, which can result from the capsule of the liver being stretched. Secondly, there can be symptoms related to the spread of the cancer. So if it spreads to bone, you can get bone pain. And there are general cancer-related symptoms such as lethargy, anorexia, and weight loss, which in the context of HCC tend to occur when the tumor is more advanced. HCC is relatively unique in that it is one of the cancers we diagnose frequently without the requirement for liver biopsy by what are called non-invasive criteria. And this is because we've become very good at diagnosing different lesions in the context of cirrhosis. So if on ultrasound you have a lump which is more than 1 centimeter, a new lesion which is more than 1 centimeter in size, the patient should undergo a contrast-enhanced CT scan or a contrast-enhanced MRI scan, one or both. If there are characteristic features, the HCC can be diagnosed confidently without a biopsy. If there aren't those characteristic features, the patient will undergo a biopsy. If the lesion is less than, or the new lump is less than 1 centimeter in size, the sensitivity of further investigations in diagnosing a liver cancer is actually quite low. And so under these circumstances, we recommend a repeat ultrasound scan in 3 to 4 months. Although this sounds a bit of a strange approach and can be quite frightening for patients, the concept is that lesions less than 1 centimeter in size may disappear on further imaging. They may come and go. And secondly, if it is an HCC, you won't miss an opportunity to provide a really good treatment if it's followed carefully and if it increases in size to above 1 centimeter. The reason we're able to diagnose HCC on imaging features alone is we take advantage of the fact that the blood supply to the cancer is different from the blood supply to the surrounding liver. So the liver receives blood supply from both a vein and an artery, the portal vein and the hepatic artery, in a ratio of about 75 to 25%. As a cancer develops, its blood supply becomes almost exclusively from the artery, with no blood supply from the portal vein, and it gets surrounded by a capsule. And we can take advantage of this in various phases of an MR or a CT scan to diagnose the cancer. So in terms of the management of HCC, it's challenging and interesting because we need to understand that we're dealing often with 2 different diseases with independent natural histories, often with independent natural histories. So we're dealing with a patient with cirrhosis, but also liver cancer. Management of HCC in the United Kingdom is broadly similar to the practice in North America and Europe, and will have subtle differences compared to the practice in Southeast Asia, where the main liver disease causing HCC will be hepatitis B. Treatment allocation is based upon therapies that have received regulatory approval. So all treatments will have to go through an organization such as the National Institute of Clinical Excellence. They will do a technology appraisal and will define whether treatment should be given nationally under the NHS. If they do, then all treatment is free at the point of delivery. This can cause some delays. So there is a new immunotherapy combination, which has been approved in the NHS in August 2025, which is about 3 months later than it was approved in the rest of Europe. But when they have approved it, this is it's interesting. This is what is said in the technology approval. It must be funded in the NHS in England for the condition and population in the recommendation. Must be funded within 90 days of the final publication of this guideline. So now all patients for whom it's suitable will get Durva-Tremi for free. As we talked about, understanding how to treat HCC depends on a number of different factors. The cancer itself, how large it is, whether it's spread to blood vessels or outside the line, but importantly, how good the liver function is, and also the general health of the patient. In general, if you have good liver function and performance status, several treatment options are available. If the patient has liver failure, the only treatment associated with improved survival is liver transplant. And if general health is very impaired, so general fitness is very impaired, and we use what's called performance status to define that, it's questionable whether someone will be able to tolerate and benefit anti-cancer therapy. I was part of some United Kingdom guidelines. I was one of the authors on the United Kingdom guidelines for the management of hepatocellular carcinoma. And this is the algorithm that we came up with, which is slightly different from that endorsed by the Barcelona group, which is commonly used in Europe and the United States. I won't go through this in detail, but I'll just talk in general principles. It's important that you have a multidisciplinary approach. It's important that on your tumor board, you have an expert radiologist, a hepatologist who's interested in the management of liver cancer, a surgeon interested in resection, in surgical treatment, a transplant surgeon, an oncologist, and an interventional radiologist as well. And it has been shown that this method of delivering care is optimal and associated with benefits, survival benefits for the patient. The UK model for rarer, more specialized cancers is for these multidisciplinary team meetings to occur at centers, or to be centered in hospitals which are experienced in managing the cancer, with referrals from district hospitals within a defined period, within a defined region, sorry. So for example, King's, our referral areas, Southeast London and Southeast England. The referrers will provide documentation outlining the case, clinical data, and radiology. We will give management advice, and this may be review at our specialist clinic within the hepatology, surgical, or oncology HCC clinic, according to what treatment modality is most suitable for them. Or in some cases, unfortunately, we may say that supportive care locally is the best treatment. We co-manage with the local centres. The specific treatments are often performed at King's, with the investigations required in between treatments, such as imaging and blood tests, performed at the referral centre. So I'm just going to run through a few of the different stages of liver cancer and what our recommended treatments are. So for early stage HCC, and what we mean by this is that the patient has a limited volume of cancer within the liver and good general health. And we're aiming here for long-term survival. And our treatment options are liver transplantation, the best treatment if the patient has liver dysfunction or more than one tumor, but strict criteria are applied. Surgical resection, where the cancer is removed from the liver. It's important that there is very good liver function and that results are best with a solitary cancer. Ablation, where heat treatment is used to disrupt the tumor, is best for small cancers and good liver function, in patients with good liver function. Intermediate stage HCC, the patient has cancer within the liver, but too much cancer in terms of size and number to consider surgery. The patient also has good liver function and good general health, and our aims will be a survival of more than 2.5 to 3 years. And the treatment options here include what's called intra-arterial therapy, so transarterial chemoembolization, and increasingly we're using selective internal radiation therapy. Systemic anti-cancer therapy may be the best treatment for certain patients, especially those with a large burden of tumor. Advanced stage HCC, the patient has a cancer which has invaded the blood vessels or spread outside the liver, again with good liver function and good general health. Our treatment aims are survival for more than 2 years, and the mainstay, the backbone of treatment, is systemic anti-cancer therapy. Some patients may be suitable for selective internal radiation therapy. And lastly, unfortunately, some patients present with terminal stage HCC, where the patient has cancer which is too advanced to consider liver transplantation and has, in addition, liver failure or very impaired general health. It is important to see if anything can be done to reverse the liver failure or improve health. So, for example, if alcohol is the cause for the cirrhosis, there can be significant improvements with abstinence. There can be significant improvements in liver function if viruses cause the underlying liver disease and are effectively treated. But it's important to have discussions about the patient's need. So treatment options, palliative care, and treat any reversible causes of liver failure. Those slides were in part a simplification, and increasingly what we will see is the employment of multimodality treatments if and when the patient progresses from early stage to intermediate stage to advanced stage. So, for example, they start with low volume tumor and ablate, and then move on to treatments such as transarterial chemoembolization if and when the disease progresses, etc., etc. We also have the reverse phenomenon where treatment can be used to downstage the cancer. So you may start with someone who has quite an advanced cancer, but is treated with either systemic therapy or selective internal radiation therapy. The cancer shrinks, and we can think about treatments such as resection or transplantation. So multimodality treatments for patients to optimize their overall survival is increasingly what is being done. There have been great advances in systemic therapies for advanced hepatocellular carcinoma. For a long time, the only approved treatment was a tyrosine kinase inhibitor called sorafenib, which was associated with limited efficacy and significant side effects. Immunotherapy has revolutionized the treatment for advanced stage HCC, although is associated with significant adverse effects. The patient needs to be fit to be able to tolerate it. And so we have now first line, second line, and potentially third and fourth line treatments for patients with advanced stage HCC. So what are the challenges facing us here in the UK? Well, we have suboptimal survival with 5-year survival rates less than 20%, despite understanding of the risk factors, despite surveillance, and despite potentially curative treatments. And one thing we really need to understand is how we can prevent patients presenting with this late stage disease when treatment options are much more limited. Health inequality, as we talked about, increased incidence in certain ethnic groups, increased incidence and mortality in deprived population. Is the current model of healthcare delivery suitable for these groups? Are we engaging them in the way we should be engaging them? And a geographical variation in healthcare access and provision. Wait times for specialist assessment, radiology, and treatment remain problematic. National targets have been imposed in order to tackle this. And this is one thing you can do with an NHS. You can have national targets. So in the end, what we need to do is to prevent premature death in patients with HCC. And there's a variety of ways we can do this. And I'm going to work through this slide and outline the approach in the United Kingdom. Liver disease and liver cancer now has a profile nationally that it never did previously. And we have a great deal of a great debt to organisations such as the British Liver Trust, the major liver charity, which have pushed forward the importance of liver disease to members of Parliament such as this lady. A group of us now go to the Houses of Parliament and perform various liver investigations on the MPs. Their FibroScan values are a bit higher than they'd want them to be. There are going to be 3 big shifts to how the NHS works. There was recently a 10-year health plan for England. And actually, I think it fits in quite nicely with what we should be doing with HCC. We want to shift care from hospital to the community. We want to shift from analog to digital. And we want to shift from treating sickness to preventing disease. So how do we prevent liver disease? National policies to reduce transmission of viral hepatitis, reduce alcohol abuse, and encourage healthy lifestyles to prevent obesity and the metabolic syndrome. There have been moves to increase price of alcohol and certainly significant education on its harms. Hepatitis B vaccination is standard in newborns and those at high risk of exposure. Labelling of foods and so-called sugar tax, hot off the press, energy drinks in the UK have been banned for under 16-year-olds. And education right from the age of 5 regarding the importance of diet and exercise. I think there needs to be a reorganisation of liver services to serve and engage the patient most effectively. For the majority of people, before they get advanced liver disease, their care should be community-based and not hospital-based. And we need to really focus on health inequalities. Consider the unique considerations and opportunities for each ethnic group. Make sure that patient literature is in appropriate language, and engage community leaders such as imams and pastors. deprivation, that patients who are deprived are unfortunately the least able to access healthcare due to the costs involved just from traveling to the hospital, for example, and also are the least able to take time off work. Patients who are diagnosed with cancer in the UK are, as standard, given a £200, $250, $300 pot of money for travel expenses, etc. But for some, it's not enough. We've moved to doing blood tests and clinics at weekends so that those from deprived quartiles don't have to take time off work. And the opportunities provided by digital medicine, but also the potential pitfalls for those who are less IT savvy. That's really important to remember as well. There are several innovations in the UK to detect liver disease early. Firstly, the education about the silent nature of liver disease and education to avoid the stigmata that surrounded liver disease previously. Viral hepatitis testing in all patients is offered to all patients presenting to the emergency room. There are community buses performing ad hoc fibroscans to identify patients with advanced liver disease in the community. And increasingly, one-stop community hepatology evaluations for those with risk factors for chronic liver disease and abnormal liver tests. Patients will commonly have blood tests and a full liver profile, and a fibroscan, a non-invasive marker of how scarred the liver is, and then are either discharged back to their primary care, the general practitioner, with education and care plan, or fast-tracked to hospital care if there is evidence for advanced fibrosis. Prevention of and reversal of cirrhosis, as we've spoken, early and urgent referral to hepatology for those with advanced fibrosis. We have very effective treatments for viral hepatitis B and C. Support in the community and hospital to achieve abstinence. We have a very, very well-formed alcohol and substance misuse team, a fully formed team at King's and many hospitals who will provide support to those who have alcohol use disorder to become abstinent. Medical therapy to control and reverse metabolic syndrome is going to be very interesting. The GLP-1 agonists will be of great interest. I'm still a bit concerned of what will happen when people stop taking the GLP agonists, unless during that time they've indulged in exercise and a more healthy lifestyle. And really making sure, I've talked about people with steatotic liver disease and not advanced fibrosis moving out into community. On the flip side, the rarer liver diseases, the autoimmune liver diseases, the genetic liver diseases, where experience is concentrated in the specialist centres, those people need to be fast-tracked to the specialist centres. Effective screening, we are forming a national and regional database of patients at risk of HCC. A national screening programme is being developed with agreed protocol and recall. But I think the real advancements will come when we have improved screening techniques. Abbreviated MR, an MR scan which doesn't use contrast or all of the images that come with the standard MR, will likely supersede ultrasound in some patients, such as those with fatty liver disease. And panels of biomarkers, including those with circulating tumor DNA, will be a much more effective way of characterizing who is at risk of HCC. Use of artificial intelligence. So the aim really is to maximize the proportion of patients who are diagnosed with early stage disease. Optimizing treatment of HCC. I can't emphasize how important it is that management is discussed in an expert MDT. So patients are have access to all treatment options, and all treatment options are discussed for them. We'll see a refinement of patient selection for each treatment modality. We're seeing rapid incorporation of new and novel treatment modalities, such as selective internal radiation therapy, stereotactic body radiotherapy, and what's called irreversible electroporation, which is another ablation techniques. There will be further developments in systemic therapies, including the use of neoadjuvant and adjuvant treatments to surgical and ablative treatments. So, for example, prior to surgery, giving a period of immunotherapy with a view to controlling and shrinking down the cancer so that the results from surgical treatment are improved. That's called neoadjuvant treatment, or giving treatment after surgical treatment after giving immunotherapy after surgical treatment in certain patients who have high-risk cancers. When you look at them under the microscope, that's called adjuvant treatment. In terms of personalized medicine, it will become more personalized. We're not quite there yet if you compare us to hematology and some of the cancers in some of the blood cancers, because the majority of mutations we've identified in liver cancer are not thus far targetable with a specific drug. AI, huge opportunities with AI in terms of biomarker panels, in terms of looking at scans and freeing up radiologists to do the interventional procedures, drug discovery, etc., etc. So huge opportunities with AI in the future. So to conclude, hepatocellular carcinoma is a hugely important public health problem. Despite us understanding the risk factors for the cancer, and despite us having a broad range of treatments, including treatments associated with good 5-year survival, the overall survival for patients really remains suboptimal. And there are a number of key things we need to do to prevent premature death from this cancer, including preventing liver disease. In those who have liver disease, preventing it becoming advanced, and in those who have advanced liver disease, diagnosing cancer at an early stage. Thank you so much for your attention.
Dr. Suttle, thank you so much. A huge thank you for sharing your expertise and perspective with us on HCC and the care that you provide and your colleagues and researchers provide in the UK and where it's heading. It's really important for us to come together to support our liver health and liver cancer community, and we are really proud to align and work with you. So thank you. And I want to thank our viewers today, too, for joining us in our session today. And I hope that you will continue to engage in our events for the rest of the month during our October is for Livers campaign. Please be sure to check out and find more information about Global Liver Institute and our work at globalliver.org or explore livercentral.org, our hub for all things liver cancer resources and research. Once again, Dr. Suttle, thank you so much and your commitment to advancing our liver cancer care.